Thanks everyone for joining this afternoon. As I said, my name is Mike Padula. I'm a neonatologist and informaticist here at CHOP. And I wanted to take this opportunity to cover some ways we've had experience with leveraging terminology standards as well as clinical document architecture that we use in HL7. Mention that I have no financial disclosures or conflicts of interest. So briefly, I want to touch on the organization HL7. It's an international standards development organization. It's nonprofit, supported by volunteers from both academics and vendors and various different groups, public health groups. And their standards are used in more than 90% of clinical information systems in healthcare. Their sort of mission is to provide a framework and standards for the exchange, integration, and sharing and retrieval of electronic health information. And the area which I think people are most familiar is their messaging standards. They also have work in electronic health record functional profiles, clinical document architecture, and then a new growing area called fast healthcare interoperability resources termed FHIR, which I'm not going to cover much now, but it's something to keep your eye out for. So the name HL7, everybody, it's one of the first questions people mentioned, refers to the OSI reference model for the way data is sent and received and sort of the packaging that goes with it. So HL7 refers to things relating to the seventh layer, the application layer, and that's really at the point at which you use your interface. And the way I sort of think of it is, you know, what you're concerned about is this data here, and then you have different sort of headers as you move down to get it to the rows of zeros and ones at the bit layer. That's just a brief background on the name. Now, the reason HL7 sort of came into being, if you will, is back initially when they were trying to have clinical information systems communicate. They realized that the cost of developing interfaces was prohibitively expensive, and then the need for connecting more and more systems had increased dramatically. So developing a standards-based approach was helpful as more information systems existed. So there are, as I mentioned, there are a number of points within HL7, but far and away the most common exists with the messaging standards for particularly version 2 messaging. So most of your information systems will deal with your demographic data, admission, discharge, transfer data, etc. And that's in the standard older versions of, well, not older, but version 2 messages of HL7. And as you see the example here, it's a an XML-based file, but it has all these bars and carets to divide information. Version 3 is a model that uses XML, and it's more object-oriented. I'll touch on that using the reference information model. And this allows it to be a bit more readable, but the XML also enables it to be processed in other ways. However, the same information that exists in the version 2 message takes about 7 more times the space and real estate in a version 3 message. Now, at this point, adoption of version 3 represents a very small fraction of the use in clinical information systems. So even here you can see they're up to 2.6 actually in terms of version 2 standards. but the overwhelming majority represent older versions of the version 2 messaging, and then even a smaller fraction represent version 3 messaging. But the version 3 is the one I wanted to focus on mostly. So for that, I'm mentioning the clinical document architecture, which is a document markup standard for the structure and semantics of an exchanged clinical document. When we mention a document, we mention something that has permanence, it's time-stamped, it is whole, it has a whole, represents an entire concept, and I'll show examples. And this, the anatomy of, before I get to the levels, I want to touch on sort of the structure of a CDA document. So in short, you have an entire document, and within that document, every document has a header and a body. And depending on the level of the CDA, you can also have different sections in a narrative block, and then different entries within that. Now there are templates that might exist for the entire document level, as well as templates that can exist at the section level or entry level. And this is really the biggest point to leverage, is that these templates are poised for reuse. So you can incorporate a number of these sections in other document types. So level 1 CDA is the most basic. It includes just a header and a body, and the body can have almost anything in it. You could send an MP3, you could send just a PDF, it could be whatever you wanted. You just basically have this wrapper that can identify what the content is. Then level 2 is a little more structured. It can have a body with more narrative blocks, and each section is identified with a code. Typically it's a LOINC code, but it can vary. And then level 3 is a CDA header plus an XML body that has narrative blocks and entries. The section can be encoded with the full reference information model, and it leverages more of the reference terminologies. These can include anything from a clinical statement, so you could have area where you have a narrative block describing certain findings in an echo, and then you could even have a structured clinical statement that calls out an ejection fraction, or some other value that you could then parse and reuse later. And these sort of CDA templates are really, there are several types, and they're used for not only clinical documents, but then also some reporting, which I'll comment on as well. So one of the hallmarks of CDA involves the phrase semantic interoperability. It took me a couple times before this really sort of started to sink in. But so if interoperability is the exchange and use of data, semantic interoperability is the ability for computer systems to transmit data with an unambiguous shared meaning. And so by that you're saying when one clinical information system is referencing a concept, another clinical information system is referencing the same concept, then you know that you're speaking like. So that requires both the syntactic interoperability, so the framework and the structure of defining the message, as well as the terminology. So you have the coded elements, including their definitions and relationships. So when we get to the sort of syntax and the way these clinical phrases are structured, it brings us to the HL7 reference information model. And it looks a little daunting, but it's really meant to model all the relationships that occur within healthcare. So you could, for example, have an example, I apologize, it's tough to see. We could have an area of something relating to substance administration. And then you can even define the actors of who administered the drug, to whom was it administered, whatever their details. The drug itself would be referenced to reference terminology, RX norm, and you can even define everything from the different status and results. And anybody familiar with object-oriented programming, you get to see pretty clearly sort of how these entities sort of relate to one another and how this was derived. So the most common, or most the CDA with which people are likely most familiar is the continuity of care document. And so what the continuity of care document is, it was a, you had something that the ASTM, which is another standards organization, had developed a continuity care record. And what that was is it was a snapshot perspective for a patient, identifying the pertinent clinical, demographic, and administrative data. So basically, they wanted something that focused on transitions of care, and they said, hey, when this patient's being discharged or this patient is going from one step to the next, what are some of the essential elements that we would like to know? And the challenge was that it was a singular use case. It was XML based, but it was still a singular use case. And what they had done was combine that with the clinical document architecture to come up with a continuity of care document. And that enabled the ability to structure this information in templates and reuse them. So if we look at what's in a CCD, these elements have certain required sections and a number of optional sections. Now, I'm not going into a ton of detail of every last one, but there are a lot of areas where any of these sections could then be reused in another document. So you could have another document type, which will touch on like a history and physical, and it may mention your medications, allergies, your problems, your immunizations, etc., in addition to a history of a present illness and your past medical history. Or you could have a discharge summary, which also includes things relating to a plan of care or other aspects. But this was the point from which most of this was started. So after that was established, there was a project known as the Health Story Project, which looked for documents that would cover some of these other use cases that people commonly were encountering. So it had everything from history and physical, a consult, progress note, op note, diagnostic image reporting, discharge summary, procedure note, etc., and even an unstructured document. And so for each of these subtypes, they created their own clinical document architecture. And it sort of helps round out some of the requirements, and we're able to reuse a lot of these different templates and subsections. Now, the one challenge with this, however, is that HL7 had developed their continuity of care document, but then another organization would develop their CDA, and then another organization would add additional constraints on that, on what it took to conform, so that, for example, they have the HITS PC32, which is a version of the HL7 CCD with additional constraints, or you could have another CDA, which IHE, the Integrating the Healthcare Enterprise, added their own constraints for messaging. There are advantages to that, but the challenge became that over time, there were too many implementation guides, so that those implementing the systems said, well, which one are we using? Are we going to use the HITSP guideline, or are we going to use another guideline? And sometimes there's conflicting information. It just became a little too much to manage. And if you look at the initial CCD, it was fairly brief, but it referenced so many other implementation guides that it became really unwieldy. So then it came the project to consolidate clinical document architecture, what they call consolidated CDA. And this is something that's gotten a lot of, been on people's radars now as it's cited in Meaningful Use Stage 2. And so this includes both the continuity of care document, which we have touched on. In Meaningful Use 1, they reference the HITS-BC 32 as the CCD that they're talking about. And when we get to Stage 2 of Meaningful Use, they're using the one that's incorporated within the consolidated CDA. So when you reference consolidated CDA, you wouldn't necessarily send every template within that. What you would do is you would take a subsection of these templates that make up whatever the required and/or optional fields are for history and physical, or an op note or procedure note, so that you basically can assemble or generate an instance of any of these documents from your existing information. The ones in red are the ones that are cited in Meaningful Use Stage 2 now. There's in HL7 right now, they're currently validating additions to that regarding a transfer note, as well as a longitudinal plan of care. So sort of each of these have their own specific use case. I think most clinicians are familiar with what's involved in history and physical. But one important distinction is that a continuity of care document is fairly brief, and it's really focused on transitions at the encounter. And it's distinctly different from a discharge summary, which has other elements such as a summary of hospital course or other required elements. So, as I mentioned, one of the reasons that this has become under increased attention is due to the American Recovery Reinvestment Act, which include the High-Tech Act and Meaningful Use. And as I mentioned, it references not only use of the consolidated CDA for use in exchange, but it also calls out the specific reference terminologies that are important for referencing your information and modeling. And for reasons that I mentioned earlier, that's it's helpful to point everybody to the same standard. So if you'll excuse me, as I mentioned, I'm a neonatologist, so I just wanted to touch on sort of a reason I got into any of this standards and interoperability work, and describe some of our own use cases for CDA as well as the reference terminologies. So back in 2006, a bunch of medical directors and other patient safety officers and folks working on quality improvement were frustrated about the limited knowledge about best practices and outcomes for infants at tertiary NICUs. So there was already a well-established network known as the Vermont-Oxford Network, which is about 900 different centers internationally that report data on very low birth weight infants. So those are premature infants less than 1,500 grams. And for those infants, the benchmark is for patients at a given gestational age or a given weight, what's your incidence of these comorbidities or outcomes? So among your babies that are less than 750 grams, how many of them develop intraventricular hemorrhage or necrotizing enterocolitis or bronchopulmonary dysplasia, which is a severe lung disease? And that has been a helpful benchmarking measure, but the area of frustration for children's hospital NICUs was that we had ill-term infants that were referred to our centers for surgical and subspecialty complications. And a lot of those infants came to us with these very complications. So using that as our benchmarking measure became frustrating because they said, well, what's your incidence of necrotizing enterocolitis or retinopathy of prematurity? And we'd say, oh, it's high because when they acquire this at the outside institutions that refer to us. So then we realized we need to be able to measure our own data and outcomes and just find out what's the variability in treatment for these patients and what are the difference in outcomes. And it also allowed us to start to capture diagnoses that are relatively rare, happen in 1 in every 10,000 deliveries, but now with a larger network, we can see this is CHOP's experience, this is Oakland Children's experience, Columbus's experience, and start to get real numbers. So briefly, we developed this consortium and essentially focused on optimizing tertiary neonatal care. I'll try and move quickly through this. We developed data fields, looked for a partner with their database, and ended up choosing the Child Health Corporation of America, which actually is the administrative database, was the administrative database for about 47 different children's hospitals nationally, freestanding children's hospitals. This has since merged with NACRI to become the Children's Hospitals Association. And one of the valuable tools which I'll relate to is it also has a very robust administrative database known as the Pediatric Health Information System, with everything from all the charges and medications administered and everything for all patients. And so with that partnering, we developed the Children's Hospital Neonatal Database. And what we have here is we have, for every admission within the NICU, we have a set of core data, and we have additional information if they have what we call a term as special diagnoses. And we enter most of this information through a web collection tool. But one of the initiatives that I wanted to touch on is we developed a CDA for getting some information. So we developed what we call the Health Level 7 Neonatal Care Report CDA. And this is a Level 3 CDA that's based in XML. And it reuses a number of the components that are used within the CCD. And a similar example for reporting is that there's a CDA for all of the healthcare-associated infections. So if you have a bloodstream infection or a lab-confirmed bloodstream infection, ventilator-associated pneumonia, catheter-associated UTI, there's a way to model that so that it could be reported within CDA, and you can use that to report to the CDC or to other agencies as well. So we created this subset of information. So we had about 700 or 800 data fields, and we took about 70 of them and modeled them within the clinical document architecture. And then it can be rendered in a human-readable form. And this goes for every type of CDA. So you can take that XML, and I wonder if I can zoom in more without losing my place. I apologize. But basically, you can get information, patient-level information, various demographic information, everything from payer to here we have we basically took things that we thought if they existed in the EHR within structured form and weren't without ambiguity, then we would report them. So structured data such as birth weight, gestational age, various measurements, APGAR scores, and various lab values and vital signs we were able to capture. Things we avoided for this start were even things as simple as diagnoses, because we didn't feel like there was enough common governance among the use of problem lists and other coding to maintain an adequate data definition. It's something we worked towards, but at this stage, we realized that that would be a tough topic to tackle. The way it works is we take information from our clinical information systems and can supplement it if need be, and generate the neonatal care report. And then we're now poised to collect information from these different sites and studies. So we can, this is a pretty basic example, but basically the primary reason for referral nationally is for respiratory or surgical reasons. And then we can look at disease-specific short-term outcomes. So, in the past 3 years, we've had more than 50,000 admissions, and you look at certain conditions which are relatively rare, but as of even several months ago, we had more than 400 infants with diaphragmatic hernia. We had almost 800 with gastroschisis, and then we can ask questions to say, well, what's the variation in care? So this is just a variation in cost and usage of H2 blockers and PPIs using the FIS data set as well to say, well, why is there so much variation there, and how do we work towards figuring out what best practices are? So so that's the basis for the clinical document architecture for our example of the CDA. But I also wanted to touch on another project that we did through the Children's Hospital Neonatal Database, and that is an initiative that was started related to the National Children's Study. Now, the National Children's Study is a longitudinal study following patients from the prenatal period through 21 years of age, and the focus is looking at the effects on the environment, such as pollution, family dynamics, community and culture influences, as well as genetics, on growth and development and health of children. This was not an NIH-sponsored funding. This is actually an act of Congress, ironically, to sponsor this program. Now, the initiative that we undertook was a formative initiative known as the Neonatal Research Network Terminology Harmonization, where we sought to harmonize the terminologies from 3 existing data sources: the Children's Hospital Neonatal Database that I mentioned, the Vermont-Oxford, which is that perinatal database, and then we also took the NICHD, which is a division of the NIH. They're a neonatal research network. And formative research in this initiative was focused on time-limited activities to address specific technical or methodologic questions. And it was essentially development of infrastructure via capacity building. So understanding that terminology was essential was important. So understanding that data sharing and integrated analysis relies on harmonizing, if not standardizing, critical concepts. There's an aim to develop a consistent terminology within the domain of child health that could be used across disciplines. So to give an example of terminology harmonization, this is the harmonization of child life stages. And what we have here are sort of a timeline of the different age spans from gestation to 0 to 1 month, 2 to 12 months, etc., going up through childhood. And you can see how this concept of age is modeled in different standardized terminologies. There's a way SNOMED refers to it, the CDC, the American Academy of Pediatrics, CDISC, which is its own consortium, EPA, etc. And what we look to do is map where these concepts, how each of these sections map to a given concept within a harmonized terminology, and provide cross-mapping. And so harmonization is meant to align concepts so you can sort of identify when you have similar or like data that you're identifying the same, even if you're not using the same term, that you're identifying the like concept. And so it's really providing a common reference to disparate data sources. And an example, if you will, is some people refer to it as a Rosetta Stone, where you have one concept, one message, but different renderings of that same messages in the different clinical information systems or research networks. So and this brings me back to sort of our own use case and how we get our own clinical information systems to bridge from what is clinically useful to getting back to those reference terminologies. So within an EHR system, it probably isn't the most useful or functional mechanism to have SNOMED-CT as your list of diagnoses. It's not the way clinicians often think. They wouldn't necessarily be familiar with the terminology that they use on a day-to-day basis. So you have most systems use what you'll call an interface terminology, which are more user-friendly terms for the clinicians. And they also, you can sometimes have multiple synonyms that identify the same concept. So, if somebody refers to a patient with Down syndrome or trisomy 21, you know it's the same concept. Or you could have a retinopathy of prematurity, which used to be known as retrolental fibroplasia. It's the same disease, same concept, just different names for it. And what you do is you take these reference terminologies and you interface terminologies. One example that is used commonly, at least at CHOP and elsewhere, is intelligent medical objects is a commercial product, but they map some of these interface terminologies to reference terminologies. And then you have, on the back end, a reference terminology that enables and facilitates storage, retrieval, and analysis of clinical data. As I mentioned, some of these terms may not be used commonly, but one of the most important things is to be able to leverage the structure for relationships. Often these terms are hierarchical. Sometimes they can be multi-axial or have multiple or polyhierarchical, and I'll talk about that in a second. But the main concept, for example, SNOMED-CT is one of the is considered a fairly comprehensive reference where of clinical terms, providing comprehensive coverage of diseases, clinical findings, etiologies, procedures, organisms, etc. And it is fairly immense, but one of the advantages to having it grouped in a hierarchy is that when you're analyzing data, you can go to something like a parent concept and get all of its related concepts within its children. So in this example, we have a tracheoesophageal fistula, and there are different subtypes of that. So you may have apologize. I'm going to try that again. I don't know why that's, pardon that. Tracheoesophageal fistula, and below we have a tracheoesophageal fistula without atresia of the esophagus, or tracheoesophageal fistula with atresia of the esophagus. Both of those are children of that other concept. To give an example of polyhierarchy, you could have a condition such as pneumonia, which is both a type of infectious disease and it's a disease of the lung. So it could have two parents. Another reference terminology that was cited for meaningful use that is useful is RX norm, which is has both generic and branded drugs, and also is run by the NLM, and also is helpful for knowledge-based systems. And the another one, which actually is quite extensive, is LOINC codes, the logical objects and identifiers. It is most commonly known for lab values, but actually, if you look closely, it has everything from different clinical observations and all sorts of data information that is really quite extensive. And if you look within the sections within a lot of the clinical document architecture, each of those sections are often identified with a LOINC code, so they know which segment or section or template you're referring to. So back to this harmonization project, I mentioned the three groups that are in it. They took subject matter experts as well as as neonatologists as well as other informaticians to manage this project, and was oversight by Apollon as well as Buzan and Hamilton. And in this initial stage, it was just to take the existing terms and map them to like concepts to come up with an inclusive hierarchy, and then with those identified concepts, map them to the reference terminology SNOMED. And the idea was just to do that for future use. So in this example, we have what we had identified as the stakeholder terms in the different research networks, and we had identified common concepts, what we call aligned concepts, where you may have a certain type of congenital heart disease, and we may call it X in one network and Y, but we came to agreement that what we're talking about is really the same entity. And then we said, well, where does that map within SNOMED-CT? How, what's the concept that we can identify? And what we found is we had a good overlap with aligned concepts. We had some concepts that were unique that had not yet been mapped, or we didn't find an entity within SNOMED. And then we also added a few other grouping concepts to facilitate later grouping for analytic purposes. So to give you an example, we had things within the cardiovascular system, and you could see the parent concepts, which are sort of farther out. You can have a type of congenital anomaly of the cardiovascular system, and you could see how, look at the hierarchy to see where the different subsections occur. So you can have tetralogy of flow and different subtypes. Similarly, you have things related to the neurologic system, where you had the different subtypes of spina bifida, and their different locations or different anomalies of the brain and their specific subsets. So after we'd done these in the different domains, what we found is that we had a certain percentage, about 18%, did not map to SNOMED-CT. So there was a gap in terms of what we found to be like concepts. We found things that were similar, sometimes a parent concept, but not necessarily the identical concept. And I guess the important thing I want to mention too about SNOMED-CT that often comes up is, and I imagine many are already aware, that you won't see something called like a pneumonia not otherwise specified, because and the thought is you could have all these different subtypes of pneumonia, but if you don't have additional specification, then you just move back to the parent concept and say it's a type of pneumonia. You're not any more specific. But if you ever are collecting data and then you are at a certain time say within our list it's not otherwise specified, then you'll have to know everything else that existed at that time to reference what categories are not yet included. So if you look at versions of SNOMED, they get away from using that similar term. So when we looked at what our terms were, some of the concepts weren't represented, and we were working on adding some of those concepts to SNOMED through the IHT SDO, which is a standard development organization that now manages SNOMED. And then the other thing we realized in this go-through is that the first pass we just wanted to identify as like concepts, but we didn't look to harmonize to any sort of data definition because we thought that would be a tall order for these established networks. But what we didn't realize is that as you're going through it in great detail, it would be great to capture when we have an exact match on a data definition versus an approximate match. So for that example, we have different definitions of necrotizing enterocolitis in the different networks. There's a definition based on Bell's criteria in the NICHD that's actually pretty detailed. It requires a list of symptoms, whether or not there was a bloody stool, different, and that list of symptoms is pretty detailed. And so the Vermont Oxford has a more simple definition with just a shorter list of categories. So you, in theory, could have a patient meet one definition but not another. So if you're comparing outcomes in these different, among these different databases, it's sort of helpful to know when you're dealing with an exact match in concept, or whether there's a different concept. So, conversely, retinopathy prematurity, there's a well-established standard, and so in all the networks, when we're talking to the different stages of retinopathy prematurity, everyone is identifying the same concept. So all these concepts were incorporated in the NCI thesaurus within its own hierarchy, and then after this initiative, we went back and added data definitions with the aid of the enterprise vocabulary services of the NCI thesaurus. It exists there, as well as the bio portal for broader dissemination. And since then, we have developed a pediatric terminology governance committee, and this is a committee which is an initiative in the NICHD as well as PEDSnet, which some of you may know Charlie Bailey and Chris Forrest have been closely involved, and it's to support the similar terminology harmonization. And so as we speak, there are currently 3 other initiatives in different domains ongoing, where they're harmonizing data definitions for adverse events, including leveraging a lot of information from MEDRA. There is a perinatology work group, as well as a rheumatology working group, and where they have taken terms from different existing sources and are harmonizing them, as well as developing data definitions. So that is one thing we are acutely aware of, and I'm not sure there's an easy solution, is that with all this harmonization work, it's almost cliche to say, well, we had all these different standards, we'll just use one universal standard to covers all the use cases, and what you wind up with is 15 competing standards instead of what you had before. And another common cliche is nice thing about standards is that you have so many to choose from. But I think there is opportunity to leverage more of this information. And from my perspective, it's really a great opportunity as we start to get to a point where, if I look at our own neonatal database, where we start to move from data abstraction to data extraction. How do we have things modeled within the EHR in terms of what exists, and then when we do have these important values or data within the EHR, how we map those to our respective reference terminologies for use, and that can be for everything from our own health information exchange within the region and region and various clinical documents, as well as reporting for quality measures. It could be reporting for various registries. So there's a lot of opportunity, and I have to give a plug. The concept of the on-ramp to interoperability is actually a phrase I borrowed from Bob Dolan, who's the current HL7 president, and sort of the take-home message I wanted to provide is regarding the use of clinical document architecture is that it provides incremental operability. So it's a mechanism for taking a simple CDA, and over time that can become more structured, so you can leverage more and more data, and you can begin with something simple, but then the more you have mapped to various reference terminologies, then the propensity for reuse is taken. So that's about all I have, but I welcome any questions.